From theheart.org, Medscape Cardiology, this is the Bob Harrington Show. Dr. Robert Harrington is the Stephen and Suzanne Weiss Dean of Weill Cornell Medicine and Provost for Medical Affairs of Cornell University. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, I'm Bob Harrington from Weill Cornell Medicine in New York City, and I'm here at the London European Society of Cardiology meetings at the heart.org and Medscape Cardiology booth, using the meetings as an opportunity to meet with friends and colleagues and get them to talk about some recent things that they've been writing about. Today, I'm joined by a good friend and colleague, Dr. Dhruv Kazi from Beth Israel Deaconess in Boston. Thanks for joining us.
Thank you for having me.
Kazi is Associate Professor of Medicine at Harvard Medical School. He's also the Associate Director of the Smith Center, which is an outcomes research center at the Beth Israel Deaconess. So thanks for joining us.
Excited to be here.
So the topic I think you know that I want to discuss is a really important paper. So there's two papers. They're part of the AHA's 100th anniversary celebration, if you will. Many of the papers look back about where science has taken us. The other author, Karen Joy Maddox, you're looking forward. And they're about the burden of cardiovascular disease in 2050. One paper really focused on what I would call the clinical issues and the public policy, public health issues. Yours is focused on the economics.
Yes.
Good description?
Perfect.
Tell us what you and Karen and the other writers set out to do. What were you asked to do?
Well, as you know, the American Heart Association is entering its second century. And part of this was an exercise to say, where will the country be in 2050? Which is a long enough time horizon for us to start planning for the future. What are the kinds of conditions, both the magnitude of the disease and the kinds of conditions and kinds of people who will be affected that we should be aware of? And so we looked back and said, if prior trends remain the same, where will we be in 2050, accounting for changes in demographics, changes in the composition of the population, and knowing that some of the cardiovascular risk factors are getting worse?
Yeah, and for me, what was really striking is that 2050, when I first saw the title, I thought, wow, that's a long way away. But then as I started reading it, I said, this is not so far away if we're going to make a difference.
Absolutely.
It might take us 25 years to make a difference.
Yeah, especially if we set ourselves ambitious goals, we're going to have to dig deep. Business as usual is not going to get us there.
No, I mean, business as usual. I mean, what I think has happened is we've spent so much time taking care of acute illness.
Yeah.
Case fatality rates are fantastic. I mean, I was making the comment yesterday to a colleague, when I was an intern, the 30-day death rate from acute myocardial infarction was about 20%.
Oh, wow.
Now it's 5%.
Yeah.
I mean, that's a big difference in a career.
There are fundamental trends. So the decline in case fatalities is a really positive development, and I would hope that going forward that would continue. But those are risk-adjusted death rates. Right. And what is happening is that risk is going up. And so this is a function of the fact that the U.S. population is aging. 2030 will be the first year that all the baby boomers will be over the age of 65. By the mid-2030s, we'll have more adults over the age of 65 than kids. That aging of the population is going to increase risk. The second is, and this is a positive development, we are a more diverse population, but the populations that are minoritized have higher cardiovascular risk for a variety of reasons. And so as the population of Asian Americans increases and doubles, in fact, population of Hispanic Americans doubles, we're going to see an increase in risk related to cardiovascular disease. And then the third is, over the last decade, there are some risk factors that are going in the wrong direction.
Yeah, let's talk about that, because that's humbling.
Yeah.
Despite all the work, I'm involved, as you know, with the American Heart Association, as are you. Despite all the work on Life Simple 7 and now Life's Essential 8, we still got some issues, serious issues.
Yeah, and then the big ones that come to mind are hypertension, diabetes, and obesity, all of which are trending in the wrong direction. So hypertension, we were gaining traction, and then over the last decade, we've slipped again. So as you know, national blood pressure control rates have declined in many populations.
And rather substantially.
It's substantially so, which has implications in particular for stroke rates in the future and stroke rates in young adults in the future. And then obesity is a problem that we at a population have very little control over.
Yeah.
We're already at 40% on average, which means that some populations are already in the 60% range.
And obesity in kids, and so we're now
dramatic.
the burden, I'll call it, of obesity. It's not that you've become obese in your 30s or your 40s.
Yeah.
You're becoming obese as a teenager.
Exactly.
Or even younger.
Since the 1990s, obesity in U.S. adults has doubled, but obesity in U.S. children has quadrupled.
Yeah.
So starting from a lower base, but it's a very much an escalating problem.
Diabetes is tightly linked to it, but not totally explained.
Exactly.
Yeah.
Exactly. The increase in diabetes is largely driven by obesity, but probably also driven by changes in diet and lifestyle that don't go through obesity.
Yeah, it's interesting. I think I have this figure correctly. It used to be rare that you saw a child with type 2 diabetes, or what we call type 2 diabetes.
Yeah.
Now that's the majority, the vast majority of
yes.
with diabetes have
type 2.
Type 2.
Yeah, especially in the adolescence, young adult stage group is all, most of it is type 2.
So diabetes going up, obesity up, hypertension not well controlled, smoking, combustible cigarettes, way down.
Yeah.
Cholesterol levels, I was surprised. Cholesterol was better. And you said, because I was at a meeting where somebody asked you, that's not explained by treatment.
No, it's not. So, and it's at least going back to the 70s, but likely even sooner. I think that can only be attributed to substantial dietary changes. We are consuming less fat and less trans fat, and it's possible that those collectively are improving our cholesterol levels, possibly at the expense of our glucose levels, because we basically substituted fats in our diet with more carbs at a population level.
So some things certainly trend in the right direction, but others in a really difficult direction. And what it's going to lead to pretty large changes in the risk of coronary disease, atrial fibrillation, heart failure.
Yeah. I want to go back to the tobacco point.
Yeah.
The definitely marked declines in tobacco, still tightly related to income in the country.
Yep.
So you see much higher prevalence of tobacco use in lower income populations. But it's unclear to me where it's going in kids. So we know that combustible tobacco use is going down, but e-cigarettes are going up. And what that leads to over the next 30 years is unclear to me.
Yeah, that one is a really important comment that's worth sort of sidebarring, which is that the vaping use has been terrible epidemic amongst our high schoolers. And what that's going to lead to, is it going to lead to use of combustible cigarettes? And we're going to see that go back up.
It remains to be seen.
Remains to be seen.
But going back to your point about this change in risk factors and this change in demographics, both aging and becoming a more diverse population, means that we have large increases in some healthcare conditions. Big ones are actually coronary heart disease goes up some, this big jump in stroke, and that's nearly doubling in stroke, which is related to hypertension, obesity, and an aging population and a more diverse population. And changes in stroke in the young, atrial fibrillation related to again, hypertension. And so we're seeing these projections, and with them come these pretty large projections in changes in healthcare spending.
Big. I mean, it's not sustainable. Give the audience the number. It's pretty. Frightening.
So we're talking about a quadrupling of healthcare costs related to cardiovascular disease. Over 25 years. I mean, these are, we've kind of gotten used to the narrative that healthcare in the U.S. is expensive, drugs are expensive, but this is like an enormous problem, an unsustainable problem, like you called it. It's a doubling as a proportion of the economy. I was looking at this this morning, that if the U.S. healthcare economy were its own economy, it would be the fourth largest economy in the world.
So the healthcare as it is today, what is it, 21% of our economy?
17% now. But if it were its own economy,
it'd be the fourth largest.
It would be the fourth largest in the world. We are spending more on healthcare than all but 2 other countries, total economies. So it's kind of crazy.
And we're talking about a quadrupling.
And within that, the cardiovascular piece is a big piece, and we're talking about a quadrupling
and that's
of that
both
piece.
direct and indirect costs.
The quadrupling of costs is just the direct costs. The indirect costs for the listeners, it refers to not costs related to healthcare, but changes in productivity, either because people are disabled and unable to participate fully in the workforce, or they die early. And the productivity costs are also increased substantially as a result. If you look at both healthcare and productivity, that goes up threefold. So these are very large changes.
So let's now get to what can we do about it?
Yes.
Because I made the comment to you when I first read the papers, I was very depressed. And then after I went through my Kubler-Ross stages of depression, death, and dying. I came to acceptance.
Yeah.
Okay, what are we going to do about it?
Yeah.
What are we going to do about it? I mean, this is like a focus on policy, but also a focus on how we deliver healthcare,
Yeah.
how we think about healthcare, how we develop drugs, devices. The drug question is going to be the one the audience is thinking about. They say, well, what about GLP-1 agonists?
Yeah.
Aren't those going to save the day?
Yes and no. I'll say that early in my career, I used to be very attracted to simple solutions to complex problems. And I've come to realize that simple solutions are elegant, attractive, and wrong. We're dealing with a very complex issue, and I think we're going to need a multi-pronged approach. And the way I think about it is there is a group of people who are very high risk today. How do we help those individuals? And then how do we help the future generation so they're not dealing with the projections that we're talking about? My colleague, Karen Join-Maddox, who led one of the papers, as you mentioned, she has an elegant line in the paper where she says, projections are not destiny. These are things we can change.
If nothing changes, this is what it's going to look like.
This is where we're headed.
We can change.
Exactly.
And we've got some time to change, but we don't have forever.
Yes, exactly. And we picked the 25-year timeline instead of a let's plan for the next century timeline because we want something concrete and actionable. Yeah. It's close enough to be meaningful, but far enough to give us the runway we need to act.
So give me two things from a policy perspective, because it's mostly policy.
Yeah, I mean, there's policy and clinical interventions. I think from the policy perspective, if I had to list two things, one is expansion of access to care. As we talk about this big increase in the burden of disease and risk factors. Yeah. So if you have a large proportion of your population that has hypertension or diabetes, you're going to have to expand access to care to ensure that people get treated so they can get access to this care before they develop the complications that we worry about, like stroke and heart disease, that are very expensive to treat downstream. And the second is, I think, more broadly related to access to care is the access to medications that are effective. You bring up GLP-1s. I think we need a real strategy on how we can give people access to GLP-1s at a price that is affordable to individuals, but also affordable to the health system, and to help them stay on it. So GLP-1s are transformative in what they do for weight loss and for diabetes, but more than 50% of people who start it are off it at 12 months. Yeah. And so there's something fundamentally wrong about how we're delivering GLP-1s today. And so it's not just about the cost of the drugs, but the support system people need to stay on.
I've made the comment in many forms now that we know the drugs work.
Exactly.
Now we got to figure out how to use them.
Yes.
And using them includes chronicity, that we can't, this is a chronic condition.
Yes.
And it's not, in some people, they can come off the drugs, but many they can't.
Yes.
So we're going to have to figure out, and maybe the newer generations of drugs will help us address what people call the off-ramping.
Exactly.
How are we going to do that? I think you're spot on those. That's critically important questions.
And then I think fundamentally, as we looked at this modeling, I'll tell you, I had a come to Jesus moment where I was like, there is no way to fix cardiovascular disease in the US without going through obesity and diabetes. We have to address obesity in the US. We can't just treat our way out of it. No. Obesity is fundamentally a food problem. And we've got to engage again with food policy in a meaningful way.
Well, as you know, with the Heart Association, we're doing a lot of work now in food as medicine.
Absolutely.
Medicine, and trying to figure out what are the levers that we can pull.
Absolutely.
To actually help people eat healthier diets.
Yes. And so rather than framing it as an individual choice that people are eating poorly, it is like, how do we make healthy diets the default in the environment?
This is where you get to the children as well.
Exactly.
I could talk about this all day. It's been fabulous I've had the benefit of reading the papers now a few times, talking to you on several occasions. Thank you for joining us here at theheart.org. And thank you, the listener, for joining us here at theheart.org and Medscape Cardiology. My guest today has been Dr. Dhruv Kazi from the Beth Israel Deaconess in the Smith Center in Boston, where he's an associate professor of medicine at Harvard and an associate director of the Smith Center. If you, as the listener, have enjoyed this podcast, please take a moment to like, subscribe, or even write a review. This helps us reach more of you as healthcare professionals. And if you don't like it and you didn't enjoy it, tell us why. We're trying to find things through your feedback and engagement that we can make improvements on the podcast. So thanks for listening.